Chapter 24, the wrist, hand, and fingers. Slide 1. In this chapter, you will learn about the common injuries related to the forearm, wrist, hand, and fingers. These include contusions, fractures, and dislocations. We will also review rehabilitation principles for these joints. Please use this presentation to guide you in your reading. Once you have completed the readings and corresponding presentation for this chapter, you can begin to prepare your responses to the forums. Slide 2. Review the bones, muscles, nerves, and blood supply of the forearm, wrist, and hand using the presentation and textbook. Slide 3. In this section, you will learn about the common injuries to the forearm. Please read the information from the slides as it corresponds with the textbook. Grasp your forearm and notice how it lacks padding. Contusions are painful because of this, and they can cause extreme bruising, swelling, and a hematoma. The initial treatment consists of rice, followed by ice therapy the following day. It's important to pad the forearm with sponge rubber or other padding to prevent chronic contusions from occurring, especially in such collision sports as football. Slide 4. Forearm fractures rarely occur to just the ulna or radius unless the mechanism of injury is a direct blow. The student athlete may experience an audible pop or cracking sensation, along with grinding, referred to as crepitus. There may be obvious deformity and swelling. If the student athlete is experiencing extreme pain or signs of shock, implement your emergency action plan. Treatment consists of casting, followed by rehabilitation of the elbow and wrist to increase strength and range of motion. Slide 5. Review the bones, muscles, nerves, and the movements of the hand, wrist, and fingers using the presentation and textbook. Slide 6. Wrist sprains usually occur from a hyperextension injury or falling on an outstretched hand. However, they can also be caused from flexion and twisting. This is the same mechanism of injury for a fracture, so it can be quite difficult to distinguish if the wrist has been sprained or fractured. It's best to refer to a physician and get an X-ray for diagnosis if you are unsure or if the individual has reduced range of motion or strength. Rice and non-steroid anti-inflammatory drugs can be used for pain. A splint will be applied during the healing process, followed by strengthening exercises for the soft tissue of the wrist. Slides 7 and 8. Carpal tunnel syndrome is a common nerve compression condition that affects athletes and the general public alike. Overuse and poor mechanics makes one prone to this condition. The carpal tunnel lies under the transverse carpal ligament and becomes inflamed and swollen because of overuse. This results in the compression of the median nerve. The individual will experience tingling, numbness, and pain over the palm of the hand and into the thumb, index, and middle finger. The Fallon test, demonstrated on this presentation, assesses for carpal tunnel. If the individual experienced increased pain in this position, it is determined that the carpal tunnel is inflamed and the median nerve is being compressed. There are many treatment strategies for this condition. Rest of repetitive activity and ice massage are the first line of treatment. The individual may also be fitted with a day and night splint as shown in the presentation. Massage and stretching may alleviate some discomfort Advanced treatments include cortisone injection, and finally, surgical decompression of the transverse carpal ligament is warranted if all other strategies fail. Slide 9. Scaphoid fractures, also referred to as navicular fractures, are the most common fractured bone to the wrist. This is usually caused by falling on an outstretched, hyperextended wrist. This injury is difficult to distinguish from a wrist sprain, and some of these fractures are overlooked. The most common way to distinguish between this fracture and a sprain is to check for point tenderness directly over the navicular bone, referred to as the anatomical snuff box. If pain is present, the athlete should be referred to a physician for X-ray. Because of the poor blood supply to this bone, extensive immobilization is required, and sometimes a screw is inserted surgically to fix the bone and enhance the healing. Slide 10. The hamate bone is fractured from a similar mechanism of injury as the navicular bone. However, it usually occurs when the athlete is holding an implement in the hand, such as a bat, racket, or other club. The pain is felt in the palm of the hand in line with the fifth finger. Treatment includes ice, immobilization, and referral to a physician for X-ray. Immobilization and padding of the hook of the hamate is the treatment of choice. Slide 11. Wrist ganglions are either fluid-filled cysts or injury to the muscle that causes the fibers to protrude through, creating a bump. They often grow at a slow rate, sometimes following an injury to the wrist. They may or may not be painful. If they are painful, the old method of removing the cyst was hitting it hard with a book. Check out some of these funny clips on YouTube. A better approach is to have a physician aspirate or surgically remove the cyst and apply a pressure bandage to prevent it from refilling. If the cyst isn't painful, it is recommended to leave it alone, even though it may be unsightly, as seen in the presentation. Slide 12. Subungual hematomas are a collection of blood that occurs under the nail bed. This occurs in sport when the athlete drops a weight on the foot or the finger. Initially, the individual will experience pain, and you will observe black and blue, also referred to as ecchymosis, developing under the nail. Ice the nail immediately using a cup of ice water if it occurred to the fingernail. If the pain and pressure continue, use one of the methods listed in the textbook to release the blood. However, I do not recommend you using these techniques on anyone but you or your family members. I do not recommend you doing this for your athletes. Allow the athletic trainer or family physician to drain the nail bed if needed. Slide 13. Mallet finger occurs when an object, such as a ball, strikes the end of the athlete's finger, tearing the extensor tendon. The result of the tear is that the last joint of the finger, referred to as the dip joint, drops into 30 degrees of flexion. If there is no fracture, the athlete will be fitted with a splint for 6 to 8 weeks to allow the tendon to heal naturally. If there is the fracture, the athlete may need to undergo surgery to reattach the bone. The athlete should be able to play while immobilized. Do not confuse this injury as a dislocation, and by all means, do not attempt to pull on the finger following this injury. Slide 14. Boutonniere or buttonhole deformity occurs when this extensor tendon now tears at the middle joint of the finger, referred to as the proximal interphalangeal joint, or the PIP. The result is that the middle joint flexes and the last joint cannot be extended. Rice is initially used, and the athlete is fitted with a finger brace for 5 to 8 weeks. Slide 15. Gamekeeper's thumb is a sprain to the ulnar collateral ligament of the thumb. This injury is called gamekeeper because Scottish men would injure their thumbs as the men sacrificed game such as rabbits. The animals' necks were broken between the ground and the gamekeeper's thumb and index fingers. As a result, a force that was placed on the thumb would tear the ulnar collateral ligament and result in instability. Today, our athletes experience gamekeeper's thumb or a sprained thumb by a forceful abduction and extension of the thumb. Pain will be present, and the athlete may have difficulty pinching the thumb to the second, third, fourth, and fifth fingers. Ask the athlete to make a ring with the index finger and thumb on both hands and interlock them as 2 rings. If the athlete cannot hold the rings tight as he or she attempts to pull them apart, this is a sign that the ligament has been stretched. If there is obvious laxity, as shown in the presentation, this is a sign that the ligament has been torn. Rice is initially used, and the athlete is referred to a physician if there is any decrease in strength, flexibility, or if you see obvious laxity. Protective taping and bracing is used depending on the severity of the sprain. Slide 16. Sprains, dislocations, and fractures to the fingers are very common in sport. The mechanism of injury is often from a direct blow, hyperextension, or torsion, such as when the athlete gets his finger stuck in someone else's jersey. Pain is often present. In dislocations, there will be obvious deformity. It can be difficult to distinguish between a sprain and a fracture, so if the athlete experiences a reduced range of motion or strength, it's best to refer to a physician for X-ray. Do not pull out any deformity. Instead, cover the injury with a bag of ice and refer the athlete to his or her physician. Slide 17. Metacarpal fractures are referred to as boxer's fractures, as this injury is associated with boxing. Oftentimes, the 4th and 5th metacarpals are affected. Pain and swelling are often evident. Have the athlete make a fist with both hands and compare the level of the metacarpals, or knuckles. A fractured metacarpal will often result in a dropped knuckle. Apply ice, splint, and refer the athlete to his or her doctor. If the fracture is a clean break, the athlete will be fitted with a cast for 4 to 6 weeks, followed by rehabilitation. If the fracture is displaced or comminuted, the athlete will undergo surgery for alignment, followed by immobilization. Slide 18. Refer to this very comprehensive section of the chapter to understand the scope and sequence of wrist and finger rehabilitation. Explanations and diagrams of exercises are included.